Hello, I'm Dr. Najim, and this picture is showing a baby who is appearing yellow. There's a yellowish tinge to the skin and the face. That could be because of any yellow light that is basically showing over the baby. But more specifically, this is the yellowish tinge of the skin because the baby has started developing jaundice. So this yellowish discoloration of the skin and the sclera of the baby, who is about 3 to 5 days old, is termed as neonatal jaundice. And this neonatal jaundice can be physiological jaundice, can be pathological jaundice. It depends upon when the jaundice has started appearing in the baby, how rapidly is increasing, any risk factors that are basically present in the baby, any underlying pathology that is evident upon examination or investigations. So all, and how long the jaundice goes, and what fraction of the jaundice is basically increasing. So normally what happens that the liver of the baby, newborn baby or the neonate, is usually not mature enough to basically conjugate all of the unconjugated or indirect bilirubin, so that it can be easily excreted in the urine and the feces. uh, and so it starts to build up in the blood, then gets deposited in the skin, so the skin appears yellow. So in the first few days of life, it is usually the unconjugated bilirubin that is basically, or the indirect bilirubin, that is increasing inside the blood. And why it's important to do an examination, a detailed examination during the first 24 hours of life in the late half, to look for any pathological jaundice that has just started, and then to have a follow-up checkup at 3 to 5 days of life, so that you can look for the intensity of the severity of the jaundice that the baby has developed. So because this indirect bilirubin is very dangerous within the first 7 to 10 days of life, because the indirect bilirubin, it is lipid soluble, it is able to cross the blood brain barrier, and it can get deposited in the brain. So when it gets deposited in the brain, mostly in the basal ganglia, so what happens, it can cause neonatal seizures, acute bilirubin encephalopathy that can ultimately progress to kernicterus. It is usually irreversible, an untreatable condition, and causes a permanent morbidity to the child in the form of mental handicap and intellectual disability and the hearing loss, and later on the development of cerebral palsy. So this is very much important to deeply assess the child, and to look for any pathology, depending upon the examination, anything you have noticed in the examination, or any history of blood group incompatibilities, or any previous history of jaundice in a previous baby who got admitted, or who accidentally got trapped or affected by the excessive bilirubin levels. So the workup is usually required in the pathological jaundice when the jaundice starts to appear in the first 20 to 24 hours of life, or it progresses so severe that at 3rd to 4th day of life the baby is deeply jaundiced. The baby is deeply jaundiced, then you have to go look for any blood group incompatibility, any underlying hemolysis, any blood accumulation at any site within the uh, body in the form of cephal hematoma, or and any inherited hemolytic diseases in the form of G6PD, or congenital causes of indirect bilirubinemia like Crigler-Najjar syndrome, uh, and so on. And certain physiological conditions also there, like breast milk jaundice, breastfeeding jaundice usually starts to appear earlier. Breast milk jaundice is a bit late, and breast milk jaundice sometimes become more severe enough that it sometimes reaches the level at which the phototherapy may be required, or in very rare cases exchange transfusion. Secondly, hereditary spherocytosis is one of the condition, that is hemolytic disease, and may present with so much severe jaundice that exchange transfusion may be required in that baby, along with blood transfusion, right? So all of these strategies are then uh, all their examination findings and then the investigations. You basically decide that whether you have to reassure the parents that it is going to settle with time, or you have to do any workup. Then there is a term that is known as prolonged jaundice, a jaundice that basically persists beyond the second to third weeks of life. So, hypothyroidism is a very common cause that causes prolonged jaundice. However, some cases that do not require any therapy, like breast milk jaundice, it may persist beyond 3 to 4 weeks of life. So you have to basically that when the baby is having low risk of developing any complications, so just a follow up is all that you need after reassuring the parents, or you need to admit the child and start phototherapy, or or you have to closely monitor the child while during the phototherapy, that whether or not now exchange transfusion is needed or not.